Well, good morning, everybody. And I'd like to welcome you all to the inaugural version of Family Medicine Grand Rounds. Family Medicine Grand Rounds is replacing what we did have, which was the Research Grand Rounds. This is an attempt to broaden the scope of rounds for our entire department. My name's Doug Archibald, and I'm the Director of Research for the Department of Family Medicine. And thank you all for joining. In this very first session, we're going to hear from the recipients of our Department of Family Medicine Innovation Award winners. They're going to give a brief description of what their research program is going to be about. They're going to present for up to 8 minutes each, followed by questions. So if you have questions, just raise your hand, and either Maddie Venerable, who has been responsible for putting together Family Medicine Grand Rounds, either she or myself will address your question or give you a chance to ask the question yourself to the speakers. So without further ado, I'd like to introduce our first speaker this morning. That's Dr. Kheira Jolin-Dahel, and she's going to be speaking on a tool to predict C-section in rural populations. She did her medical school here in Ottawa in the French Stream and completed her residency training in rural Manitoba, where she worked for 4 years prior to coming back to the Ottawa region. She's currently on maternity leave, and she's working in Winchester, where she offers a full scope of family practice, including clinic, OB, and ER. She is also the Director of Quality Improvement for the Department of Family Medicine. In her spare time, she does research, and her interests are in obstetric and rural primary health care. Most of all, she's a proud mother of 3. So Kheira, I'll now move it to you to take over.
Great, thank you very much for this great introduction. Okay, so I think I have you ready, but I'm Dr. Jolin, and my research is a tool to predict C-section in rural delivery. Do I ask you to move on to the next slide, Maddie? Is that how it works? Yes, okay. I thought I would start with some fun facts. So childbirth is the #1 reason for hospital admission in Canada. It's approximately 360,000 per year. It's closely followed by COPD admission at 89,000. So definitely a huge user healthcare system. And then obviously it's easy to make the conclusion that C-section is the #1 preferred surgery in Canada. It's closely followed by, any guess? Sorry, oh no, anyway, it's knee surgery. I thought that I wasn't expecting that. Anyway, so now we can move on to the next slide, please. Okay, so giving birth is a wonderful experience. You get to take cute baby pictures, and then you end up with a beautiful, healthy baby. Nothing can go wrong, right? Next slide, please. What if I told you that instead you had to take a 17-hour bus ride to a city that you've never been, with a different culture, and you may not speak the language? You'll be staying in questionable accommodations, and but that's okay because we're paying for you, but not your partner. You can bring him, but you have to pay. And we are not responsible for arranging other childcare for children that you may have at home. And you have to leave 4 to 6 weeks prior to your due date and stay there the whole time. But it's okay because that's in your best interest. Does that seem right to you? It doesn't seem right to me. So in Canada, there's about 6.1 million people that live rurally, and that's close to 20% of the population. There's few rural and remote communities that offer intrapartum care, and First Nation community are particularly affected by the situation I just described. Next slide. So despite being far, there's many position statement and evidence that support that implementation of rural intrapartum care, so that's labor and delivery services, even without access to a cesarean section. In general, communities that offer intrapartum care carefully select lower risk patient and initiate transfer when needed. And that's all in the labor and delivery time. So we know that communities that offer labor delivery services have good outcome. They have higher vaginal delivery. They have decreased neonatal mortality, greater sense of empowerment, and better psychosocial outcome. Next slide, please. And so even when you have low risk pregnancies and labor is going well, some patient may require an unplanned C-section. And deciding on the timing of that transfer can be challenging. Next slide. Currently, even if you're in a tertiary care center, the decision to go for a C-section has a lot of different variables that comes into play, and it's usually varies between providers to providers. So for the same patient, the same scenario, a provider will call a C-section a lot earlier than the next provider. And then if you're in a rural remote situation, in addition to all of these factors, you also have to add in weather and like availability of other services. So transport might be used for another patient, so you have to take that in. Okay, next slide, please. With all that in mind, I thought that a tool that would help predict the risk of a C-section birth based on factors that happen during labor could help to decide when to initiate the transfer. And that would help to support a decision-making that is currently a little bit subjective into a more objective process, and help decrease some of the anxiety that might be experienced by the providers and the patient when that situation arises. Next slide. So I've already have a prototype of this. It was made on data from rural Manitoba. We had over 2,000 births. They were including one of the largest First Nation community and one of the other non-First Nation rural community. And the positive predictive value for vaginal delivery was 91.5%. So it's quite optimistic. The problem is we did have a fairly limited number of charts. They were all paper chart. It was extremely time consuming. And we had limited number of unplanned C-section. And it's easy to predict a vaginal delivery. It's your most common outcome. Next slide, please. So to overcome this limitation, I thought about using the Ontario Better Outcome Registry and Network database, so the BORN data. And using their data from 2012 to 2018, we would include all singleton vertex pregnancies, so head down one baby, at 36 weeks or greater. And that's because it's considered not term in obstetrical, but old enough for the baby to deliver. We're in the unit that doesn't have NICU. And then we would exclude all C-section and childbirth and stillbirth, sorry. So using the BORN data would allow me to access, rapidly access a large data set, and it offers opportunity to include variables that I did not have access in the first chart review. And then we could also conduct secondary analysis of complications of immediate complication of childbirth. Next slide, please. So these are just some of the factors that we're going to consider. Some are quite obvious, like maternal age, parity, gestational weeks. Other one, like maternal weight gain, we know there's some effect, but it's not clear how much it actually affects the birth outcome. So we're gonna consider all of these. The statistical analysis will be a multivariable logistic regression model where two sets of the data will be used to produce the model, and one set will be used, will be used to validate it. And that will be done by a biostatistician from the Ottawa Method Center. Next slide. So the outcomes are the rate of C-section estimated by the model versus the actual rate of C-section for the patients. And the secondary outcomes will be maternal and neonatal complications. Next slide. And so I want the tool to be made into a smartphone app because that's very convenient for a clinician, and it's allow for widespread of the information, and it's practical clinically. So this is the prototype that was designed based on the previous data. So as you can see, it's fairly easy to use. You just select the variables that apply to your patients. They're all going to be clinically easily accessible variable, and then you calculate and it gives you the risk. And next slide. I just wanted to show all the people that are helping me with this project because I'm not doing this by myself. And I think the next slides are my reference. Any questions?
Thank you, Kheira. Thank you very much. I'll introduce our next speaker now, and that's Dr. Courtney Maskerine. Dr. Maskerine is a graduate of the University of Ottawa School of Medicine. She completed her residency at Queen's University in family medicine. She's completed the Clinician Scholar Program here with our department, as well as a master's in epidemiology. She's currently a family physician at the Briere Family Health Team and has an interest in research involving risk assessment in primary care. Just a reminder to everybody, please, if you're not speaking, if you can put your microphones on mute. And after Courtney presents, if you have a question, just raise your hand in the participant section or just make a comment in the chat, and either Maddie or myself will address you. So Courtney, I'll hand it over to you.
Thanks, Doug. So I'm going to be presenting today on the impact of modifiable risk factors on morbidity compression or expansion in Canada. So next slide. So just a bit of background information first. Morbidity compression involves a hypothesis generated that suggests that with improved prevention, individuals will have less disease or disability, and that it will be compressed towards the end of life. So this would result in a greater number of healthy years of life, free from disability or chronic disease, and then resultant reductions in health, the resultant reductions in health-related quality of life that come with disability. So the research gap is that there's recent studies indicating a plateau in morbidity compression in Canada. Our ability to understand morbidity or compression relies currently on estimates of the burden of chronic disease. And so estimates are from the World Health Organization and the Institute for Health Measurement and Evaluation. And these current estimates for global burden of disease rely on data that's been stratified into groups based on age and sex. And in addition, they also use a single disability weight for different diseases, despite evidence that health-related quality of life varies dependent on multiple factors, including socio-demographic factors, health behaviors, and comorbidities. So there's gaps in the ability to accurately and discriminately estimate chronic disease incidence, to understand the roles that various predictive factors have, such as socio-demographic and behavioral factors, and to make conclusions about actual expansion or compression of morbidity in Canada. So what's the importance of this? So largely the importance of this study is at the population level. And much like Kheira, there's an entire team working on this, and I'm a research team. However, there's also the potential for the application of these algorithms in primary care for individual risk assessment tools. So the data sources for the project will include the Canadian Community Health Survey, so a population-based cross-sectional survey performed in Canada. The variables from this will include socio-demographic characteristics, health behaviors, and intermediate risk factors such as BMI and hypertension, and then proximal risk factors such as any history of chronic disease, as well as other factors such as neighborhood factors, healthcare and access factors. And one of the outcomes as well, the Health Utilities Index Mark III, will be used for health-related quality of life. Disease registries will also be used for data on individual disease entities, and then Canadian vital statistics will be used for the data on mortality. All of the data will be linked at ICS. So the analysis plan involves descriptive statistics for distributions of potential risk factors, and then the creation of a multivariable competing risk Cox proportional hazard model with 3 potential outcomes: disease incidence, the health-related quality of life measure, and all-cause mortality. And then further analyses will be done to look at burden of disease from specific risk factors, as well as potential preventive scenarios. So for example, health behavior changes or medical interventions for individuals who are at high risk, such as statins for cardiovascular disease. So one particular area of interest that I'm hoping to explore within this study is the application of these risk algorithms to primary care. I've posted one algorithm here. So current risk assessment in primary care tends to focus on single or a range of related outcomes over a very defined period, so often 5 years or 10-year risk. And this I just pulled from the internet, gives you, 4 different risk prediction models over 10 years for an individual to look at their cardiovascular disease risk. On the left-hand side, you put in all of the factors that you know about. They allow you to put in one factor for relative benefit, so you can only do one at a time. You can't add on multiple. And then you sort of get this output on the right side with a visual representation, which actually has been shown to be helpful for patients, but also a lot of numbers there, including a number needed to treat, which might be a little bit difficult for the general population to interpret. So when looking at personalized risk assessment, there's a lot of questions that remain. So are the risk algorithms we're using actually conducive to providing information to patients in such a way for them to understand and to encourage them to have some behavior modification? Are outcomes actually patient-centered? So the photo here is from this month's CMAJ, and although it doesn't have to do with a risk assessment tool, it does indicate, that there's a focus to change to patient-centered health outcomes when trying to change behavior. So patient-centered outcomes, again, would be those that pay attention to patients' beliefs, preferences, and needs. And other outcomes that could also be of interest are, instead of a 5-year risk of event, it might be something like being disease-free at the age of 65, or how many quality-adjusted life years somebody might expect to have as a result of disease or chronic disease, basically. Another question we have is there a role for including multimorbidity outcomes or health-related quality of life as one of the outcomes? So the concept of multimorbidity being that a lot of downstream non-communicable diseases share common risk factors and some similarities. And so looking at whether or not for a patient it might be more valuable to know if they change certain health behaviors, what is the impact not on just cardiovascular disease or one particular outcome, but on a range of outcomes and on their quality of life. Other questions include, can we show whether incremental changes in behavior may benefit a patient, and how to communicate uncertainty in estimates. So, there are certain assumptions in each model, and we have confidence intervals, and how do you communicate that these estimates are not 100% certain? So I think I'm still back one slide, Maddie, if you can go back one. I'm not talking fast enough. Personalized risk assessment. So looking briefly into the literature, there is a systematic review of systematic reviews showing that in general, personalized risk assessment tools have not resulted in significant behavioral change in past studies. However, some of the areas that haven't been discussed in this study included that there's no discussion of who provides the risk assessment, whether it's done in primary care, done by a specialist. There's no discussion in terms of continuity and follow-up or repeated assessments to promote behavior change. And there's a limited understanding of what actually increases uptake, with which the authors discuss maybe some fact that there's visual cues that are important. However, that's still an area that requires a lot more assessment. So next steps, I'll be looking into a literature review on risk communication. What are the best practices, outcomes that are important to patients? What are the necessary aspects, or what have we learned so far about communicating personalized risk assessment to promote behavior change? Looking at relevant timelines, and then also exploring to some extent the role for artificial intelligence and risk assessment to remove it partially from primary care office hours. So to try and make it more easy to use, that you might put all of that information into a computer program before you actually step into the office and make it more time efficient. So in summary, again, this project overall looks at multivariable risk algorithms to predict health-related quality of life, morbidity from chronic disease, and mortality. Understanding at a population level if morbidity compression or expansion is happening in Canada. Understanding the impact of modifiable risk factors on these outcomes. And then looking more specifically at the role for translating these tools into primary care practice to facilitate patient behavior change and risk factor modification. So thank you very much. I have to also say, I didn't write it on the slide, but thank you to Doug Manuel, who's my primary preceptor. Or I can't say that anymore. He's my mentor and was my preceptor for my master's project. And my last slide just shows what the week has been like this week, including my lineup at the COVID swab assessment center. So I'm sure many of you are also experiencing the same kind of weeks. If there's any questions, I'd be happy to take them.
Thank you very much, Courtney. I'd now like to introduce our next speaker, Dr. Daniel Myran. He's a family doc and DFM Innovation Award Fellow with the DFM. He's also a CIHR Fellow at the Ottawa Hospital Research Institute. His research focuses on the burden of problematic substance use and health policy. He recently completed his public health and preventative medicine training and has been working part-time for local and federal public health agencies, aiding with the COVID-19 response. So Daniel, I'll hand it over to you now.
Thanks, Doug. So I'm going to be talking today about a project looking at really the impacts of COVID-19 on the mental health of physicians. And we can flip over to the next slide. I don't have any conflicts, and the study I'm going to be focusing on today has received some CIHR funding. You can go to the next slide. So I'm particularly interested in problematic substance use in mental health and how to use natural experiments to tease out different policy implications. And my research area is going to focus on a couple of interesting natural experiments, including cannabis legalization and a lot of the ongoing change to alcohol control policy in Ontario. But of course, COVID-19 is a fascinating natural experiment, and I'm going to talk today about a planned study looking at how it may be impacting the mental health of physicians. So as I'm sure many people are aware, Canadian physicians and physicians around the world face substantial mental health challenges. A survey by the CMA in 2017 found that 25% of physicians have symptoms compatible with burnout, and over 30% will screen positive for depression. And that's something that we see in an international context. And there's been a large amount of concern that COVID-19 may worsen the mental health of physicians for a number of different reasons. And again, they're probably pretty obvious to people here, but increased risk of infection, disruption to practices, working in new and challenging environments. And this is supported by some early survey data from China and Italy, who've reported that physicians and other healthcare workers who are having direct patient contact with individuals with COVID are reporting increased anxiety and depression. So what the study that we're doing here is going to do is it leverages a linkage of all of the physicians licensed to practice in Ontario, which we obtained through a collaboration with the CPSO, into health administrative databases. And this actually, the linkage occurred pre-COVID, and the plan was to look at physicians as patients and understand a number of different health concerns and factors to them. And as far as we know, this is actually one of the largest linkages of a cohort like this to health admin data. So it's really exciting. And when COVID happened, it felt like a natural extension to use this pre-existing linkage to look at physician mental health. So there's 3 objectives. The first one is to look at the pre-COVID-19 incidence of mental health visits for Ontario physicians. And we're focusing on 3 clusters of behaviors or outcomes that I'll talk about on the next slide. And it's actually interesting because there's very little information about the healthcare use of physicians. So in of itself, I think this objective will have some good information. The second objective is to look at changes in visits during and hopefully following the COVID pandemic. We'll see how our funding window lines up. And the third objective is to look at risk and protective factors for individuals who experienced worsening or new mental health issues during COVID-19. The 3 clusters that we're going to look at, and these are very much related to what are the types of visits that we can capture using ICD-10 and DSM codes at health administrative databases, but we're going to be looking generally at mood and anxiety, so depression, anxiety disorders, and bipolar disorder. We'll be looking at problematic substance use, alcohol, cannabis, opioids, and illicit drugs. And we'll be looking at a cluster that we call suicidality, which includes completed suicides, attempted suicide, and self-harm events. And really, again, because we don't know the incidence of any of these outcomes pre-COVID, the way we look at them and the way will really depend on how prevalent they turn out to be. So in terms of the methods, we have a cohort of 50,000 plus practicing Ontario physicians, and we're going to follow them between March 2015 and March 2021. And we're also going to have a matched cohort of the general population who we're going to look at concurrently to understand if physician mental health changes differ in important ways from the general population. We'll use health admin databases at ISIS that capture outpatient care, all emergency department visits, hospitalizations, and deaths. And we'll start with some descriptive statistics, but our main analysis for objectives 1 and 2 will be using interrupted time series analyses, looking at changes in monthly rates of visits over time. And we may look at some important subpopulations, or we may, and again, it'll depend on the number of events that we see. So the 2 primary outcomes that we're going to be looking at will be acute events, which we're defining as ED visits, hospitalizations, and deaths. And we'll also be looking at outpatient care. And we're specifically going to look at primary care and psychiatry visits. And we're exploring using some of the new COVID-19 K080 codes, which I'm actually myself not super familiar with. But I think the idea is that we'll have potentially seen a large decrease in access to primary care appointments during different stages of COVID-19. And we're interested in exploring how access to the newly created K0 codes may have maintained access for certain individuals. We have 4 primary exposures and some covariates that we're going to look at. Really the main exposure here will be time. So we'll be looking at the pre-pandemic time, during the pandemic, and we'll define different stages of the pandemic, likely related to the government's official reopening stages, but we may dive deeper into what healthcare availability was at different stages in the pandemic. And then, as I said, with maybe some optimism, some post-pandemic periods. We're going to operationalize COVID-19 risk. Again, we're still thinking through the logistics of how to do this, but our preliminary thoughts are having experienced a positive test, working in a setting that has an outbreak. We initially had thought about doing variables related onto the number of tests that people might have received. But I think that I think we really need to understand what that looks like for the physician population. There may be some physicians who have a medical order, for example, where they have hundreds or thousands of tests that have been written in their names. The third exposure, we're going to look at existing mental health conditions, which will likely define as 1 or more visit for that condition in the year prior to COVID-19. And we're working with some, there's some collaborators at CAMH right now who are actually coming up with different definitions for this purpose for looking at mental health changes during COVID-19. And finally, we'll look at income and employment. and we'll capture that through OHIP billings. And then the CPSO linkage and the ICS data allows us to look at age, sex, residency type, specialty, et cetera. So we'll look at those as well. We have 4 overall hypotheses. I suspect that physician visits will decline during the pandemic and increase between waves and following the pandemic. What we're particularly interested in is looking at the ratio between acute care to outpatient care, because I suspect that outpatient care access will decrease in physicians and the general population, but that the rate of acute care events may decrease less. So the proportion of people who are seeking acute unplanned care may increase, and we would use that as a signal of worsening mental health or of mental health concerns. And I'm not convinced that there's actually going to be a large difference between the general population and the physician cohort, but I do think that there will be specific vulnerable physician groups. It might be individuals working in the ICU or the emergency department, individuals with pre-existing mental health conditions, or people who've had substantial loss of income or disruption to their practice, who may see a greater risk of worsening mental health. And next slide. So there's a couple of challenges and limitations. The first 2 are really, physicians are less likely to seek care behavior for mental health and addiction. And when physician visits of these type do occur, they're less likely to be coded as mental health visits. So I think that going into this, we're being very upfront that we're capturing the tip of the iceberg of physician mental health. And this is not supposed to represent all physician mental health, but that if we do see changes in these sorts of behaviors, it probably represents much larger changes going on that are not captured using these databases. And I think that the last limitation is that healthcare use has probably changed in important ways during COVID-19. And we're going to try and mitigate that by looking at how healthcare use in the general population has changed, and possibly through the comparison of acute, more inpatient or severe outcomes and outpatient primary care. So I just wanted to acknowledge Dr. Tani Saputro, Dr. Doug Manuel, who are both my fellowship supervisors, and a number of co-investigators here in the DFM, including Dr. Maga, Dr. Kendall, and Dr. Tani Saputro, who are all assisting with this grant, and we have some excellent other collaborators and co-investigators.
Wonderful. Thank you very much, Daniel. Thank you very much. Great presentation, Daniel. I'd like to now introduce our next speaker, Dr. Parisa Rezaiefar. And Dr. Rezaiefar is a family physician at the Briere Academic Family Health Team, assistant professor in the Department of Family Medicine, a clinical teacher, former refugee, and above all, a mother of 2 amazing girls. Her interests are in medical education with a focus on simulation and technology for teaching and evaluating competence in ambulatory women's health procedures, humanity, and advocacy. She's also completed a Department of Innovation and Medical Education Fellowship. So on to you, Parisa.
Merci beaucoup. J'aimerais tout d'abord remercier le département de médecine familiale de l'Université d'Ottawa pour la bourse de soutien d'innovation. J'aimerais également remercier le Conseil médical du Canada pour la bourse d'études de WD Dauphiny. Cela m'a permis de faire une année sabbatique pendant laquelle j'ai obtenu les capacités dont j'ai besoin pour conduire cette recherche. I'm going to switch to English. So I'm going to essentially study technical skills of family physicians, family medicine. You could move on to the next slide, Maddie, please. I have no conflict of interest. We can go to the next slide. So given that this is the beginning of my project, I'm going to spend a lot of time convincing you as why this project is important, because I'm looking for collaborators and volunteers. And of course, I'm always open to feedback. So to give you an introduction, the College of Family Physicians of Canada expects graduating family physicians to be competent in 80 procedures, including ambulatory women's health procedure, which are my area of interest. It recommends that independent practice requires a certain level of experiential competence. And therefore, oral licensing exam consists of 5 simulated office orals, what we call SOOs, none of them examining the candidate's procedural skills. Next. Now, why is this important? As Kheira mentioned, 1 in 5 Canadians live in rural areas of Canada with access to only 2% of specialists. And half of Canadian forces are family physicians. So in these areas, and generally in Canada, delivery of procedures falls on family physicians. When it comes to the access, the most recent data we have is a 2018 American study of 6,000 US graduate family physicians who reported that only 53% of them was going to offer more than 1 ambulatory women's health procedure, and that one is pap smear. And then when it comes to Canada, we only have data from 2004, so quite dated. And at the time, we only showed that 40% of family physicians provide more than 1 procedure. And again, that would be PAP. So as you can see, we have significant access issue. And of course, when it comes to safety, patients have the right to have access to procedures without complication. And we know these procedures have significant complications like perforation of a uterus. Next, please. Now, when it comes to the learners, they have told us quite a bit. We know that for anyone to change their behavior, they need knowledge, they need skills, and they need attitude. When it comes to knowledge, residents tell us that inadequate procedural education during postgraduate training is responsible for why they don't want to perform these procedures. They also cite that they've had limited experience, clinical opportunities during their postgrad training. And finally, if they see that their mentors, their supervisors are not performing these procedures and they're referring them to tertiary care center by specialists, they're not going to have the attitude that it takes to provide these procedures after graduation. And then it comes to the teacher. So for me, the question is, well, when they say we don't have enough clinical experience, well, how many procedures do they need? In my years, I only did 1 IUD, and here I am performing lots of IUDs. So it's more than that. The problem, though, is that it's not only increasing the number of performed procedures, because our family medicine training is only 2 years, and there is limitation on the number of hours that trainees can work. So it's very difficult for us to increase their clinical experience. And that's the same problem in other specialties. And therefore, other specialties, mainly surgical specialties and internal medicine, have moved from just increasing clinical experience and are really relying on simulation. In this method of teaching, simulation, you use repetition and formative feedback, and the 2 of them have been demonstrated to improve competence when it comes to clinical performance. Next, please. So the bottom line is that ambulatory women's health procedures are very important primary care services, and few family physicians do them. Therefore, as a discipline, family medicine needs to explore innovative approaches to teach and to assess trainees' progression of competence in performing these ambulatory health procedures. And we do know that specific feedback and assessment drive learning and performance. Next, please. So the objective of my study is to develop a specific checklist for 4 ambulatory women's health procedures, and then evaluate their use as assessment tools using OSCE formats. Once it's developed, of course, these assessment tools can be shared with other training programs and also can be implemented for other ambulatory procedures. Next. So there are two rating instruments for assessment of technical skills. As you can see on one side, the Global Rating Scale, GRS, and on the other side, Procedure-Specific Checklist, PSC. I'm using the one that our Department of Family Medicine uses for procedural skills e-field note as a GRS model. And I'm using the other side, the endometrial biopsy PSC that we have developed to bring to the point that while GRS is a great tool, it gives gestalt in terms of performance. And it leaves with very little room for specific corrective feedback compared to the PSC on the other side, where there are observable sequential behaviors that we could use to give a specific corrective feedback on the technical skills of trainees. Now, more importantly, as you can see with the GRS, terms like a well have been used to rate the performance. That leaves quite a bit of room for rater bias, inter-rater, and intra-rater variability. Because as an individual, depending on what kind of day I'm having, I may interpret well differently. And so it leaves room for bias in terms of our final result. Whereas in the PSC, as you can see, there is no room for inter-rater variability because the points are very specific, especially when we use non-binary anchors, which we're going to be using. Next. Now, we don't have any validated tool or procedure-specific checklist in the literature. And so that's why we have developed our own. How we develop them, we develop both our instruments, OSCE, and our checklist based on empirical standards of practice, literature review, and of course, experience. So myself and Chris Kuntz, which you all know, with more than 30 years experience clinically and teaching ambulatory women's health procedure, were involved in developing these tools. Then we got Glenn Posner and Adam Gerber, both OBGYNs and simulator educators, to review them and gave us feedback in terms of the comprehensiveness of these tools. Next, we're going to do a modified Delphi. And as you know, when we don't have a validated tool, we use Delphi to reach consensus on what items are really important to be included in this tool. So as you can see here, again, I'm using endometrial biopsy as an example. Our original tools has 29 items. Now that's too many items. We know that the maximum item on a radar instrument should not go beyond 25 because it can cause cognitive overload of your radar, essentially fatigue, and they hate it. So our objective is to reduce the items as much as we can to maximum of 25. So on each round of Delphi, our participants are going to score from 1 to 8, 8 being very important and 1 not important at all. And on each round, the items that receive a score of 7, 8 by 70% of participants and do not receive a score of 1, 2 by more than 20% of participants will be included. And then the items that receive more than 70% of participants support as a score of 1 to 2, and that they don't receive a score of 7 and 8 by more than 20% of participants will be excluded. We'll do 3 rounds of that until we're completed. I know we're almost done.
No, sorry, thanks.
There you go, we're done. And this is our OSCE setting. So the next step is our OSCE pilot, where we're going to be piloting our OSCEs with raters and the videos that we've created from first year and second year residents to validate our tools. And then in 2021, we're going to be recruiting cohorts in PGY1, PGY2, and faculty to use that as to evaluate our tool as an assessment tool. All done. Sorry.
That's all right. Thank you very much, Parisa. If anybody has any questions for Parisa, please send her an email. We have one more speaker left, and that is Dr. J.P. Singh. JP is a family physician practicing in the Durham region. Prior to starting medical school, he worked here actually as a research manager at the BRI, working for Dr. Liddy and Dr. Hogg on various research projects. While doing his medical school training at Queen's, he also did his master's in epidemiology. And his thesis focused on the impact of patient rostering on continuity of care and access to care. Hopefully you can all stay on for an extra couple of minutes this morning to hear JP's project. So JP, over to you.
Hi, good morning, everyone. Great presentations from the rest of the speakers this morning. It's a real pleasure to have the opportunity to briefly talk to you guys today about my proposed research project. The focus of my study is really looking at the impact and utilization of the Ontario e-consultation service during the COVID-19 pandemic. So, as you all know and have experienced, the COVID-19 pandemic has resulted in unprecedented changes to the healthcare system. In particular, community-based physicians have had to increasingly rely on phone and virtual visits and have had to adapt to decreased resources in the community as many imaging facilities and labs were closed down, particularly during the lockdown. In addition, access to specialty care became increasingly difficult during the lockdown as many specialist offices were shut down or limited to urgent cases only. And furthermore, as you know, there were COVID-19 outbreaks in many of the long-term care facilities and nursing homes that resulted in lockdowns, which made access to outside medical services and specialist support increasingly challenging. And with these challenges in access to specialty care, there was also sort of the additional challenge of keeping up with the volume of new evidence related to COVID-19. Next slide. So as you all know, over the past few months, there have been a constant stream of new knowledge related to COVID-19, including its symptoms, strategies for limiting your risk, what populations were at the highest risk, and the latest treatments. And so as a primary care provider, trying to keep up with this new knowledge and applying it to your unique patient population has not always been straightforward and not come without its challenges. So with the pandemic resulting in sort of this reduced access to specialty care, and with the upsurge of new COVID-19 information, there's really a need for innovative solutions to help improve access to specialty care and to provide support for community-based providers through all this new information related to COVID-19. Now, one potential solution to help address some of these challenges that have arisen during the pandemic is using electronic consultations. For those of, most of you are likely familiar with it, but for those of you that are not familiar with the e-consult system in Ontario, in brief, the e-consult system allows physicians to use a secure asynchronous web-based tool to send patient-specific questions to various specialists across the province and to get more timely access to specialty advice. And through the portal, so basically you're able to provide a description of your patient along with any questions and attach any lab work or imaging, and the specialist will respond in a timely manner with their advice, often avoiding the need for an in-person specialist visit. Next. The e-consult service in Ontario now includes 135 different specialties, and studies to date have shown that the average wait time to get a specialist response is about 2 days. And in addition to that, there's been shown to be approximately a 40% reduction in unnecessary face-to-face specialist referrals. And also, more recent studies have pointed to the system being a very useful tool to help educate primary care providers and update their knowledge by getting the opportunity to directly connect with various specialists across the province. Next slide. The COVID-19, so sort of realizing the challenges of the pandemic and the surge in new COVID-19 evidence, the Ontario e-Consult Service developed a COVID-19 specialty group that providers could have access through the system. The system has been overseen by various infectious disease specialists and officially went live in March 2020, so around the start of the lockdown. And as of August 31st, there have been a total of 232 consults that have gone through the Ontario e-Consult service. Next slide. So the study objectives for this sort of study that I've proposed really can be broken down into two main components. Sort of the first component it focuses on assessing the impact that the COVID-19 pandemic has had on the utilization of the e-Consult service, with the hypothesis being that with decreased options for specialist referrals, that there would be an increase in the overall utilization of e-Consults. And the second component of this study is really focused around assessing the utilization and value of the new COVID-19 specialty group that was created in response to the pandemic. Next slide. So specifically stated, the study objectives, 4 study objectives were: 1, to examine the impact of the COVID-19 pandemic on the overall utilization of the Ontario e-Consult program in primary care practice, and also looking at long-term care homes. Number 2 is to examine the utilization patterns of the COVID-19 e-Consult specialty group. Objective 3 is to look at, focus in on the topic of questions that are being asked by the primary care providers and the long-term care physicians to the COVID-19 specialty group to get an idea of sort of any gaps in knowledge or areas of concern that commonly came up. And finally, the last objective is to examine the perceptions of the users and the specialists that are involved with the COVID-19 e-Consults. Now, in terms of the methodology briefly, so to examine the impact of the pandemic on the overall utilization of the e-Consult service, we'll be conducting a longitudinal analysis, sort of comparing the number of total e-Consults that were submitted to all specialties that are on the system before and after March 2020, when the lockdown was put into the place in the province. We will also look at changes overall, but also looking at conducting a subgroup analysis to examine how utilization patterns specifically changed in primary care clinics, but then also looking at long-term care facilities alone as well. Other outcomes of interest will focus on the number of providers that were submitting an e-Consult, with the thought that as the pandemic hit, more physicians were looking to e-Consult to get specialty advice, and also looking at the number of new providers that signed up for the system and started using the system, and also getting a better idea of what specialists or specialties were getting e-Consults, and sort of comparing that to prior to the pandemic and seeing if the relative utilization of the different specialties changed after the pandemic. Now, in terms of the analysis related to the assessment of the COVID-19 specialist group, we'll conduct a descriptive study using data pulled directly from the web-based portal to gain insight into the utilizations of this newly formed group. Also, this analysis will involve looking at the total number of e-Consults submitted, the average response times by specialists, and also the demographics of the patients that are being consulted about. In addition, as outlined in Objective 3, there's an interest to gain insight into the topics and specific questions being asked. And in order to do that, we'll conduct an inductive and deductive content analysis of the clinical questions that were being asked to the COVID-19 specialists, which may provide insight and potential gaps in knowledge that may help inform educational tools or CME events for providers down the road. And lastly, in order to study the perceptions of the primary care providers and specialists for Objective 4, we plan to assess post e-consult surveys that primary care providers are required to complete after finishing each of their e-consults in order to get insight into the overall satisfaction of the system and the outcome of the e-consult, and whether a face-to-face referral was still needed after the e-consult took place. In order to get the perceptions of specialists that were involved specifically with the COVID-19 group, we'll be conducting interviews with each of them to gain insight into their collective experiences and to get suggestions on potentially refining the service or moving forward. Now, in terms of the study team, I know a lot of you guys likely have to go, so just quickly, briefly, this is the makeup of the study team. In terms of the knowledge users and on the team, Dr. Gary Garber is one of the team members from Public Health Ontario, and obviously the Ministry of Health and Long-Term Care. In terms of funding, obviously partly funded through this Innovation Award, and also we've recently applied for an applied health research question as well, and plan to likely submit a grant to the PSI Foundation early next year as well. And lastly, last slide is just acknowledgements, and just wanted to thank the Department of Family Medicine and the University of Ottawa for giving me this opportunity, and to Dr. Liddy and Dr. Keeley for allowing me to be a part of the eConsult team, and to the entire eConsult Center of Excellence and the research team. Thanks.
Great. Thank you very much, JP.